series. My name is Lynn Johnson. I am the physician liaison for the Stanford Medicine Otolaryngology service line. I have a few housekeeping notes before we get started. Information on how to claim your CME credits. So let me show that to you on my screen. Information on how to claim your CME credits will be sent to you within 5 to 7 business days after the activity. These are the learning objectives for the course. We will have a live Q&A session near the end of this activity, so please put your questions in the Q&A section at the bottom of your screen, not in the chat. Dr. Hohenberger as well as Dr. Chen will answer questions at the end of both presentations. I'd like to introduce Dr. Katie Hohenberger. Dr. Katie Hohenberger is a fellowship-trained otolaryngologist and head and neck surgeon and a clinical assistant professor in the Department of Otolaryngology. And she's in the Division of Head and Neck Surgery at Stanford University School of Medicine. Dr. Hohenberger specializes in diagnosing and treating a variety of conditions that affect the head and neck, with a focus on benign and cancerous thyroid and parathyroid disorders. She offers comprehensive care for endocrine conditions, which includes in-office ultrasounds, biopsies, ablation procedures, and surgical treatments. Dr. Hohenberger's research is focused on the management of head and neck cancers and thyroid nodules. She also studies techniques for improving outcomes in head and neck surgery. So I'd like to welcome Dr. Hohenberger.
All right. Thank you so much. All right. Thank you, Lynn. As she mentioned, we're going to be talking today on the treatment of non-surgical treatment of thyroid nodules, as well as well-differentiated thyroid cancers. I have no financial disclosures. It may be a little bit atypical for an ENT endocrine surgeon to be giving a talk on non-surgical options in thyroid management. It is really, though the field of thyroid surgery is expanding, and there are now many alternatives to surgery. If we look at the new ATA guidelines, which were just released in August, now more than ever, we're going to need to be up to date on all of the alternative techniques to really practice shared decision-making with our patients. So you can see here, this is the ATA's new data framework released in that 2025 guidelines update. And I would argue, this is for the well-differentiated thyroid cancers, but I would argue that it also applies to benign disease. And it really is highlighting that we're in an era where we need to be looking at the dynamic nature of assessing the risks and benefits of all of our treatment options in an era of active surveillance, radiofrequency ablation, as well as surgery, to carry out these treatments and to monitor disease response. So today, I won't really be touching on the diagnosis of thyroid nodules and cancers or the specifics of how-tos of treatments, but instead we'll focus on understanding the technology and the techniques that are available, as well as being able to assess those risks and benefits and the expected treatment response. Specifically, we will be discussing thermal ablation for benign thyroid nodules, as well as thyroid artery embolization. Then we'll cover some of the literature on active surveillance and percutaneous ablations for outcomes and management of small, well-differentiated thyroid cancers, specifically PTC. And we'll begin with talking about benign nodule ablation. So over the past few years, there have been many minimally invasive methods used to reduce the size of benign thyroid nodules. Currently in the United States, RFA or radiofrequency ablation and microwave ablation have really kind of come to the forefront, where RFA is certainly becoming the most commonly used, and that's what I perform, and that's what I'll be focusing on more today. But both RFA and microwave ablation are typically in-office techniques. A typical setup is shown here. It is essentially a thermal probe and used to heat the thyroid tissue, and it burns the thyroid nodule. And it can really be thought of as basically a monopolar cautery type device for the surgeons. It's very similar to a Bovie. You do have to have a ground. It does conduct a current. So the patients may perceive a slight amount of current. Sometimes they'll tell us they have a tingling in their jaw or in their teeth. Or radiating to their shoulder, but that goes away when you turn off the device, and it's generally very well tolerated. So patients are numbed with a local anesthetic, may have an oral sedative if they choose, but it's very often can be performed in the office with minimal or no sedation. But like Abovie, it does have restrictions, right? It can't be used on patients with pacemakers. It can't be used on patients with cochlear implants. And so there are other options available. Microwave ablation, it's also a thermal technique, but rather than a high frequency current, it generates heat via an electromagnetic field. It can be used in patients with pacemakers, so it does provide an option for those people, and does have a larger zone of treatment effect of thermal injury. But with that larger zone of treatment does come a little bit higher rate of injury to surrounding structures and slightly higher complication rate. And which is why we're all excited that coming down the pipeline is a technology called nanosecond pulse field ablation, which is not a thermal technique, but rather uses a higher electrical current to induce cell death via a process of electroporation. Oh, sorry about that. But it does electroporation, which disrupts ion gradients and causes cell death without risking thermal injury to surrounding structures. So this is really in clinical trials in the United States. It does often require sedation as the current is perceptible to the patient, and they kind of describe it as like a static shock type of sensation. But regardless of the exact type of ablation that's being performed, the general criteria for the procedure is the same. It's indicated for patients with nodules that are greater than 2 centimeters. They should be solid nodules or mixed solid and cystic, whereas our cystic nodules can be treated with a combination of ethanol ablation or ethanol ablation alone if it's a dominant cystic nodule. We do still require that patients have 2 benign thyroid biopsies. But now we're in an era where most providers have been treating atypia of undetermined significance nodules, as long as they have subsequent benign molecular testing, and that has also been demonstrated to have a safe treatment profile. And so, but we really do only recommend treatment for patients that are symptomatic, right? We're trying to avoid unnecessary risk. Thyroid nodules, as you all know, is super common. We're not looking to treat nodules that are not causing compressive symptoms or cosmetic concerns, or showing that they're progressively growing. There are certainly some contraindications to RFA beyond patients who have a pacemaker. The nodule does have to be accessible via a transcervical approach. Sometimes these nodules are predominantly substernal or might not be a good option, or patients can have factors that limit access to the neck. Patients with significant airway narrowing from the nodule, there's a risk of swelling post-procedure, and it's not recommended to treat those patients. And then there's a whole host of patients who can't lie flat for one reason or another, or can't come off of their anticoagulation, and that would be a relative contraindication. But what you'll notice isn't on this list is an upper size limit, right? There is no defined size at which you can't treat a nodule. And I'll say we at Stanford have treated nodules really up to 10 centimeters and had good success. How do we define that success? So technically, it's a 50% volume reduction. And we often get much better than that. I would say a typical nodule, we are getting around a 70% reduction at a year. And we can get that 70% reduction in the vast majority of our patients, probably better than 90%. And we are seeing a 70% reduction in our nodules, whether they're greater than 5 centimeters or less than 5 centimeters. There are some factors that can predict a better response and maybe a better candidate for RFA. Certainly people who have smaller nodules at baseline, patients who have a normal rim of thyroid tissue to allow you to treat the edge of the nodule are better candidates, especially if the nodule is not next to the trachea or vital structures like the recurrent laryngeal nerve. Nodules that are less vascular are also better candidates for ablation. There's a heat sink effect with high blood flow. So with thermal technologies, it does limit the nodule ablation. And then patients who are TPO antibody negative, we find have a better response. But none of these are an absolute contraindication. And I've treated patients with all of these factors, and they are typically still able to get about a 50%, at least a 50% reduction. And what's really more important than getting a 50% reduction is getting improvement in the patient's symptoms. And what we find is that improvement of symptoms. When we look at thyroid quality of life outcome measures, patients' symptoms often improve before they even get to a 50% volume reduction. When we look at our cohort at Stanford, we find that, as early as 4 to 6 weeks, most patients have improvement in their goiter symptoms, improvement in their cosmetic concerns, and their overall quality of life scores. And that improvement is typically preserved, whether the nodule is less than 5 centimeters or greater than 5 centimeters, and it is sustained for at least that first year. There are, of course, risks with radiofrequency ablation. I think, the biggest disadvantage relative to surgery, and it surprises some patients when they're referred for their initial consult, is that we're not going to get rid of the nodule, right? Patients still are going to need surveillance, and the nodules can start to grow again. And depending on the factors of the nodule, it's usually, you quote the patient, about a 25% risk of nodule progression at 5 years. But there are certainly factors that will play into that based on how completely you're going to be able to treat it. There are also, of course, procedural complications. There's a 1 to 2% risk of a temporary nerve injury and some risk of permanent nerve injury. And of course, risk to regional structures, right? The trachea, to the esophagus, to other nerves and vascular structures. There is a risk of hematoma, which is relatively low. And then unique to RFA, we do sometimes see thyroid nodules rupture. So this isn't, a complication that happens during the procedure. It's a delayed complication, weeks to months after ablation, where the devitalized nodule, rather than being resorbed, which is what typically happens, it can form a fistula tract and drain out of a cutaneous fistula. It's extremely rare, but it does happen typically in very thin patients or patients who've had surgery previously. But really, the largest benefit is that the risk of hypothyroidism is very low, less than 2%. Some studies will say 0.05%. And this is really the biggest motivator for patients, right? We live in a save your thyroid era. And this allows patients, to avoid taking thyroid hormone replacement more frequently than with a lobectomy. And so that is really what drives patients to choose to proceed with RFA more so than the cosmetic concerns of having a scar. It really is that they want to avoid thyroid hormone replacement. And generally, we are getting patients that are very satisfied, right? These tend to be very happy patients. It's nice to see them back in your clinic. They often have really, really great results. They can't remember what their symptoms were before the treatment. So if you're interested in adopting this in your practice, I would say the learning curve isn't too difficult if you're already performing neck ultrasounds in your office. And it's recommended that you're comfortable with fine needle aspirations before learning RFA. And there's some studies that suggest that people do about 50 FNAs before doing radiofrequency ablation. I'll say the probe is bigger. It's more like a core needle biopsy probe. And so it's a little bit easier to follow than your 25 gauge needle for a fine needle aspirate. And after you are comfortable with FNA and ultrasound guidance for needle placement, they do recommend that you do about 30 cases in kind of a proctored or observation setting or on phantom models, because that's sort of where the learning curve is to be safe and effective. And then there's really kind of another 60 cases where people kind of get better volume reduction. So in those first 60 cases, people should be choosing more ideal nodules, right? Small nodules. It's a little bit easier to do a left-sided nodule if you're a right-handed surgeon, those sorts of things, before you move on to the larger nodules with substernal extent or very vascular nodules or malignancy. While there are, of course, some startup costs. An RF generator typically costs about $30,000 in the United States for, I think 25 to 30 is what you typically will be quoted. And the probes, which are disposables per procedure, are each about $1,000. We are now getting much better coverage from insurance companies because there was a new CPT code, which was released this year. If you're treating unilateral nodules, which some people would argue you should never be treating bilateral nodules, it's about 5 to 6 RVUs versus a thyroid lobectomy, which is about 11 RVUs, but certainly something that can expand your repertoire and things that you can offer to your patients. For patients who aren't good candidates for RFA, maybe because the nodule is not accessible, but still wish to avoid surgery, there is a newer option on the horizon, which is thyroid artery embolization. So this is performed usually with interventional radiology. That's who does it here at Stanford. And it is a particle embolization of the thyroid artery, similar to what they would do for, for any sort of bleed into the neck. They can go and selectively embolize the inferior or superior thyroid artery. Initially, it was used in Graves' disease as a method to treat hyperthyroidism, but it was noted to have the additional pleasant side effect of shrinking the gland. And now it's being used. Currently, we offer it here. I know they offer it at UCLA, being used for volume reduction in benign disease. Now, the degree of volume reduction will vary based on the type of nodule that you're targeting. If you have a single dominant nodule, you're going to expect a better volume reduction because you can typically favorably target the correct vessels to reduce the blood flow to that nodule. But you can use it also in nodular conglomerates and expect to get about a 50% volume reduction as well. And additionally, it still is very effective in resolving hyperthyroidism, both associated with Graves' disease, but it's actually even more effective in those autonomously functioning glands. You see about an 80% improvement in the hyperthyroidism rates. And as most surgeons are interested in, it does typically reduce the degree of substernal extension. Studies show that it's about a 50% reduction in that substernal extent. And so this is appealing for a lot of patients who are looking to avoid surgeries that might require a sternotomy. And it is still thyroid function preserving. They don't have high rates of hypothyroidism because they are only targeting 2 or 3 of the vessels at a time. And it has a lot of the benefits of RFA, right? It doesn't require a general anesthetic. It is done under a sedation in an IR suite. But there are certainly some disadvantages. It does have a slower time to volume reduction and probably less volume reduction than what we are seeing with RFA. It does require that the nodule is hypervascular as opposed to RFA, where hypervascularity decreases your ability to treat. And there is, the most significant risk is a small risk of stroke. So in the case series in the United States, there haven't been many strokes reported. There is some Chinese literature where there's a case series of 90 patients where they had, amongst those 90, had 3 strokes and 1 death. So it may not be ideal for older patients with atherosclerosis. I will say at Stanford, they're typically only targeting the inferior thyroid arteries to minimize that risk. But certainly something to keep in mind and to educate your patients on. We don't have, really high quality long-term data on the rates of regrowth and recurrence because this is such a newer technique, but certainly something that can be offered to your patients. So I think I'd like to switch gears, and we're going to talk about a field where we are getting better long-term data, which is now the world of active surveillance and radiofrequency ablation in the management of small papillary thyroid cancers. So again, with those ATA 2025 guidelines that were just released in August, I'm sure that you will certainly be referencing them soon if you're listening to this talk. It does support active surveillance and RFA as being an option to offer to patients with small, well-differentiated thyroid cancers, specifically those micropapillary carcinomas. We do need to recognize that, of course, it is a conditional recommendation with low certainty evidence because there aren't, truly the randomized controlled trials that we hope to have. But the data that we do have is all very promising and supportive. Sorry, my slide's not advancing. And so currently, active surveillance can, and I would argue that it should be offered for patients with T1A disease. T1A disease, of course, hopefully isn't actually being biopsied that often, and we are seeing a reduction in the number of patients that are being referred with micropapillary carcinomas. But what we do know is that active surveillance, which technically is ultrasound surveillance every 6 months for the first 1 to 2 years, and then annually with the option of proceeding to surgery, is safe and effective. So we would proceed with surgery if there's growth of the tumor, and that growth needs to meet at least a 3 millimeters of growth in the axial dimension, or there needs to be changes on the ultrasound characteristics. Basically, higher risk of invasion to surrounding structures or any evidence of nodal metastases. Patients need to be able to be seen quickly with the surgeon and move forward with an operative arm if we're choosing active surveillance. And with these paradigms, they find that surgery can really be avoided or at least significantly delayed in nearly 90% of patients. Probably the best long-term data in the United States is coming out of Memorial Sloan Kettering. They published their series of active surveillance in their cohort of tumors that are less than 1.5 centimeters, so not quite just the less than 1 centimeters that the guidelines are referencing. And the Memorial Sloan Kettering data shows that even with a cutoff of 1.5 centimeters, 70% of patients at 10 years will have no change in the size of their disease, and 15% of patients will actually have a decrease in the size of their tumor. The flip side of that is that 3 to 5% of patients will still go on to develop lymph node metastases, but that this isn't actually different really than what we would expect patients who undergo a total thyroidectomy up front. We would still expect about a 3 to 5% of patients developing lymph node metastases. And so those patients that did get surgery after active surveillance, they'd found that they didn't need a more extensive surgery, and that there weren't higher rates of complications. So, really, it's been well demonstrated that in appropriately selected patients who are closely monitored, we can safely offer active surveillance. But we know that it still isn't always right for everyone, right? I think as surgeons, we often see patients in our office who are deeply conflicted. They're already patients who, for one reason or another, have decided to get a biopsy of a sub-centimeter papillary thyroid cancer, which, right, is not indicated by the guidelines unless it's at risk of invading a critical structure. And so I think these patients do tend to already have a little bit more health anxiety than your average thyroid patient. And that anxiety really can guide the conversation about what's best for the patient that's sitting in front of you. But, I think it's a little reassuring to look at some of the outcomes data on how anxious patients are when they are treated with active surveillance versus surgery. It turns out that patients are really good at self-selecting which branch they're going to be happier in. So patients who choose surgery up front tend to be more anxious than patients who choose active surveillance. But we don't find that patients are treated with the surgery, that the anxiety does not decrease significantly for patients once they've had the surgery. They still have a high level of anxiety about disease recurrence, whether they're on an active surveillance arm or immediate surgery. The rate doesn't change from where they kind of start at the baseline. And so, we do have some data about how many patients would choose active surveillance if it was available to them. The biggest study is actually a Canadian study, so clearly a different healthcare system. But it does suggest that 90% of patients with T1A disease in their system chose active surveillance over surgery when given the option and when they were able to provide access to that care. But of course, we do have an intermediate option, which is to perform a percutaneous ablation for patients with small papillary thyroid cancer, which appeals certainly to some patients when they're on the fence of, should I go with surgery? They don't want to have surgery, but they don't want to do nothing. There is a good number of patients who are interested in percutaneous ablations. And there is a recent international consensus statement that was also published this year that suggests that thermal ablation can be offered for T1A tumors safely. Again, these are those micropapillary carcinomas. Ideal candidates really do need to have a 2 millimeter rim of normal thyroid tissue around the tumor. So things that are on the posterior capsule or near critical structures, again, are more difficult to ablate and may not be appropriate. And there is, of course, some increased caution in some specific cases of T1A disease. Specifically, multifocal disease might still be T1A, but if there's less than 3 foci, things with minimal extracapsular extension, or especially if they're just kind of elevating the capsule anteriorly, or thyroid isthmus nodules, those might still be T1A disease, but really are not thought of as being good candidates for radiofrequency ablation because of the higher risk of multifocal disease and recurrence. And so those patients really should only be offered surgery or active surveillance, and they can consider radiofrequency ablation if they've refused those first-line treatments. I will say there are people that are treating T1B disease, much more common in Asia where they're a little bit ahead of us. But there is certainly a point where we might see that in the future. In the United States, really only very high volume centers are doing that, and it's typically only part of a clinical trial. So I don't think that we are offering that here at Stanford at this time. There is certainly still risk with RFA, more risk than active surveillance. Primarily, there's risk of injury to the recurrent laryngeal nerve, which is usually temporary, and typically, we quote people around a 2% risk of temporary and very, very small risk of permanent nerve injury. But despite that, we do see that patients are often very successfully treated. We think of success, it's not like when we're treating benign disease where we need to shrink the nodule in half. A successful ablation of a thyroid cancer really is 100% resolution of the tumor following therapy. And the studies show that in experienced hand, about 85 to 95% of tumors will completely respond, right? At 1 year, they will have completely disappeared, similar to what you can see in this ultrasound image. But despite the very high response rate, we do know that still about 2 to 4% of these tumors will progress. And again, about 3 to 5% will still go on to develop lymph node metastases. So it's not different if you have surgery, if you have radiofrequency ablation, or if you have active surveillance. So really the biggest benefit that we're seeing over active surveillance is reduction in the primary disease progression. There was a nice study with a computational model that factors in the risk of disease progression by age. So, right, that is kind of the biggest factor when I'm talking to a patient, when I'm trying to determine what I think might benefit them most. We know that in active surveillance of young people, especially those in their 20s, they're much more likely to progress than older patients. And if we think about, what is the number of patients that we would need to treat and put at risk for injury, what we find is that in their 20s, we would need to perform 5 RFAs to prevent one person from progressing and needing a thyroid surgery. Whereas patients in their 60s, we would need to perform 40 RFAs to prevent one patient from needing a thyroid surgery. So certainly something that we are factoring in. We should consider the age of the patient when helping them decide what option is best for them. And so, really in summary, we're kind of constantly updating our risk-benefit assessment for our patients all the time. We can help provide them the statistics, which are really that micropapillary cancer can be safely managed with active surveillance, with radiofrequency ablation, or with surgery. We're not going to see a meaningful difference in the rate of spread to the lymph nodes, but we will see a different side effect profile. We do see patients with different anxiety levels, and they have different follow-up needs, and that might change based on what treatment modality they choose. So I really hope that after listening to our talk today, you feel better able to educate your patients about their non-surgical treatment options and can help them understand how they might apply in real-world practices and in the community where you're practicing. I will say we are very lucky here at Stanford. We have all of these resources available. I personally perform RFA, as does my partner, Lisa Orloff. We also have a colleague, Julia Noel at Santa Clara Valley, who is performing the pulse field ablation on a clinical trial. And Andrew Kesselman, he's one of our interventional radiologists at Stanford. He's performing thyroid artery embolizations as well as microwave ablations. So we do have kind of the whole spectrum of treatment options available. And so I will stop sharing, and we're going to take that questions at the end. So I will turn things over to Dr. Chen.
Thank you so much, Dr. Hohenberger. for that informative presentation. If you have additional questions, please continue to include them in the Q&A, and we will answer them at the end. Next up, we have Dr. Michelle Chen, who is a fellowship-trained head and neck surgical oncologist with a board certification in otolaryngology. She also is an assistant professor in the Stanford School of Medicine Department of Otolaryngology. Her practice focuses on the treatment of cancers that affect the head and neck. She has received additional training in microvascular reconstruction and transoral robotic surgery. Dr. Chen has an active lab involved in head and neck cancer health services research, and her work has appeared in numerous journals. She also has authored chapters in textbooks and on head and neck cancer treatment. Welcome, Dr. Chen.
Thanks, Len. So yeah, today I just really want to give an overview on innovations in jaw reconstruction and dental rehabilitation for our patients. I I have a disclosure that I've been a speaker in the past for Johnson & Johnson. So in terms of our learning objectives, I really hope that after today, you'll be able to identify the key surgical techniques that are utilized in jaw reconstruction and their appropriate clinical indications, and that you feel comfortable sort of thinking about what's involved in a comprehensive treatment plan that incorporates rehabilitation strategies for patients undergoing jaw and maxillary reconstruction. And I want to highlight ways that we can collaborate effectively with our multidisciplinary teams in order to optimize outcomes, and show you some case studies that where we go through sort of planning and pre and post-operative management for patients requiring reconstruction. So much of my practice involves treating head and neck cancer patients, and a large proportion involves oral cavity cancer. I really want to focus on that. We know that across the United States, oral cavity cancer has been steadily rising in incidence for the past several decades. And there's actually increasing incidence in sort of non-typical, atypical cohorts, such as younger patients, female patients, and non-smokers. And that's very prevalent in our catchment area in the Bay Area. Treatment for oral cavity cancer typically consists of upfront surgery, followed by adjuvant therapy with path-directed radiation and possible chemotherapy. There's an emerging role for neoadjuvant and adjuvant immunotherapy in select advanced stage oral cavity cancer patients. And again, just to go over those steps, so when we think about surgical management, this is typically the first step for these oral cavity cancer patients. And surgery, if it involves the mandible or the maxilla, can involve some type of maxillectomy, whether it's just the palate or it's a total maxillectomy and an orbital exoneration. For cancers involving the mandible, we typically do a segmental mandibulectomy. And then on the same day as their tumor removal surgery, the ablative part of the case, we often do reconstruction, so that we're able to close the defect that we create. So when we think about reconstruction, we think about the reconstructive ladder, which demonstrates all the tools we have at our disposal. When we're doing sort of oral cavity reconstruction, we typically focus on the top rungs of the ladder. So we often need some kind of tissue transfer in order to seal off the oral cavity and prevent fistula. So whether it's an oral nasal fistula or a salivary fistula from a mandibular defect into the neck. And so the most common thing we do is microvascular free tissue transfer. Um, but in patients who are too sick or have other contraindications to free tissue transfer, we'll do local or regional flaps. So currently, when we think about mandibular reconstruction, the goals are really to reestablish the mandibular arch, maintain the airway and prevent airway collapse, and help with the functions of the mandible, such as mastication, chewing, swallowing, and speech. And then we also really want to re-establish the contour of the lower face and the chin. So our current options are, like we mentioned before, the osteocutaneous free flap. So the most common reconstructive option in a healthy patient is the fibula free flap because it provides a long piece of bone stock. And there's also, it's, as you can see on the photo on the right, it's relatively thick. It's not as thick as the mandible, but relatively thick, and can provide a platform for potentially dental implants or other procedures. We also, in select patients, use a scapular free flap, and there are other osteopenic free flaps, iliac crest as well. And then for patients who cannot tolerate sort of bony free tissue transfer, we do local regional soft tissue reconstruction, a soft tissue free flap, or even primary closure in some cases if they're very sick. One of the issues with any kind of soft tissue, non-bony reconstruction is that because you're not recreating the arch of the mandible, you get jaw deviation and sort of mandibular swing, and that resulting that some malocclusion, as you can see here in the picture below. So when we think about maxillary reconstruction, we actually do have the option of an obturator. So this can be sort of designed and a temporary one can be designed and used preoperatively and placed after surgery, and then the patients work with their prosthodontist to create a final obturator. Um, some of the limitations are that it can be hard to find a prosthodontist that's comfortable with advanced maxillary defects, and it can be quite costly as well. For smaller maxillary defects, we use local regional soft tissue reconstruction, such as a pelvic island flap, a temporalis muscle flap, buccal flaps, or even the nasal septal flap, and sometimes do multiple in combination and try to close off smaller defects. For larger defects or ones that start to involve the orbital rim, we think about doing sort of bony or soft tissue reconstruction with a free flap. So I just wanted to present a couple case studies to sort of illustrate, where we are currently in terms of reconstruction and where I think we have to go in order to really optimize dental rehabilitation. So I think commonly when, we see a patient with advanced oral cavity cancer, this is a non-smoker female who has a T4A anterior mandibular alveolar ridge squamous cell carcinoma. She has multiple loose teeth due to the malignancy, and she'll require a composite resection and reconstruction. And in this case, we use a fibula free flap to rebuild the defect. So you can see on the picture on the right, we're able to rebuild her arch and seal off the oral cavity from the neck. But post-operatively, she has significant quality of life concerns. She feels like there's a lot of dysfunction, and she can only eat soft foods. She also drools, or her lip collapses in because there's no dentition to hold up her lip. And then in this case, this is a patient with a left buccal and maxilloalveolar ridge squamous cell carcinoma. And for this patient, we had to do a maxillectomy as well as buccal space resection, and we reconstructed with anterolateral thigh free flap. And again, you can see here, this is sort of an intermediate picture. We actually debulked further after this, but even with a soft tissue flap, you don't get the same alveolar ridge as you have in the picture on the left. And so we lose that keratinized gingiva, the shape of the alveolar ridge, and then just because there's the flap with gravity tends to fall into the oral cavity a little bit, it makes it very difficult to get dentures in these types of patients. And so this patient is functional in that he's able to eat sort of a soft diet, but he was unable to complete his full dental rehab, and he felt that compromised his quality of life. So, despite doing our best to sort of rebuild and close off these defects, often we even use bone to maximize function. Many patients still feel that they have significant disability due to the lack of true dental rehabilitation. They often report that they have long-term diet restrictions, especially textural ones. They have articulation, body image concerns that impact their social interactions and psychological well-being. And we actually do know that like head and neck cancer survivors are at increased risk of depression and suicide compared to other cancer patients. When we think about the factors that are associated with the lack of dental reconstruction across the country, some things come up, including lack of access. So it's not offered at all centers. There's significant financial costs sometimes to the patients if we can't get it covered under their insurance. A lot of these cancer patients require radiation, and there's concerns with implanting radiated bone because that can cause osteoradionecrosis, and then sort of an infection of their bone. And there's treatment fatigue for a lot of these patients because they have to have a large surgery, a reconstruction, and radiation. And after they complete that, they often sort of decline sort of further treatment because they don't want any further procedures for their dental rehabilitation. So as you can see in the picture on the right, we're able to rebuild the jaw. We have skin sort of reline the area where the cancer is, but a lot of patients are still not satisfied. And this has been going on for a while. So since 1989 was when we actually, Dr. Erkin, an otolaryngologist in New York, first demonstrated that dental implants in the fibula was safe and efficacious. We know also that there's a high success rate when we place implants in a delayed fashion in non-radiated fibulas. It's greater than 94% on a recent systematic review. However, if implants are not placed at the time of initial reconstruction for these patients, almost none of them will actually receive them later, which is what we've noticed anecdotally as well. This is often due to radiation, cost, time, and treatment fatigue, really a multifactorial reasons. However, if patients receive implants in their fibula bone at the time of their initial surgery, then about 60 to 60% obtain a final prosthesis, which is much better than zero. And then lastly, in the last group of patients, if we can have patients undergo actual jaw-in-a-day reconstruction, where not only do they have their tumor removed, their mandible or maxilla rebuilt, but we can give them temporary teeth at the same time. In this cohort, we see that the vast majority will actually go on to get their final dental prosthesis. So this means that the sooner we can get implants or teeth in place, the more likely that patients will actually achieve dental rehabilitation with an implant-borne fixed prosthesis. So what are the steps to really integrating reconstruction and dental rehabilitation? So this requires a multidisciplinary evaluation by a head and neck reconstructive surgery team, as well as the dental and oral surgery teams. We require digital impressions that are done with an intraoral scanner, and fine cut CTs through the mandible or the maxilla, as well as through the donor site, which is most commonly the fibula. Within our multidisciplinary team, we meet together and do virtual surgical planning to create patient-specific models, guides, and hardware. And the decision on the timing of implants and how we're going to reconstruct these patients are really made based on extent of disease, whether it's been a benign or malignant process, the presence of opposing teeth, and also patient buy-in, because this can be a fairly lengthy rehabilitation process. And we always tell patients that teeth are the goal, but not all patients make it to teeth. As you can see, it varies from almost no patients if implants aren't done at the time of primary surgery. If implants are done, it can range from anywhere from 6 to 60%, depending on the case series you see. And then if implants and temporary teeth are placed, then that's the highest rate, where over 90% will get their final teeth. So I just wanted to move on and show some case studies to help demonstrate what we are currently doing at Stanford for dental rehabilitation. So this is a 70-year-old female former smoker who has a left mandible squamous cell carcinoma. And so you can see the cancer in the photo. And, she was very interested because she had a full set of teeth. She was very interested in, dental rehabilitation. So our first step is we did virtual surgical planning with our dental and oral surgery team. And we designed how we wanted to place this fibula in the defect. And so we create, models that are patient specific in terms of their mandible and their fibula. And in this case, we designed a 2-segment fibula to fit in place. And you can see that the fibula bone is slightly above the inferior border of the mandible. And so we do that in order to optimize the restorative space for the patient. And then in this case, we place 2 implants in on each segment. You can see we do not reconstruct the second maxillary molar, and that is intentional. Typically in these patients, especially this one who's getting radiation, there's a little bit of trismuth associated with that, and it's very hard to reconstruct that last second maxillary molar. And so this patient will actually have her last molar extracted during her ablative part of surgery. So in this case, because we knew she was a cancer patient that was going to get radiation, after we harvest the fibula and place the implants intraoperatively, you can see this is her mandible, and this is a diagram of the fibula that we've placed now in the jaw. We take the skin of the leg and we actually wrap it around and cover the healing abutments that we place on the implants. So you can see that here. And you can almost see, so you see, the reason is that in patients who are getting radiated, we need to cover this all, have them heal, and we uncover them about 6 months after radiation. And so the photo on the right is after radiation. It shows that the skin paddle is well healed. You can almost see the contour of the implants under the skin paddle, and the healing caps are all buried. So then 6 months later, once she is well healed, we open up her skin paddle, exposing the healing caps, switch them out to multi-unit abutments, and then we place her final prosthesis. So the whole process takes about a year from start to completion. So it does require significant patience on the patient side. This next case is a 50-year-old female with a right mandible ameloblastoma. You can see that the cystic expansile mass on her CT scan, and it's causing cortical erosion, and she's had significant loss of dentition already on the right from this. So in this case, our goal was not just to restore what she had, but also give her additional teeth, because she's already lost teeth through this process. And so again, we had our virtual surgical planning session. We planned a 2-segment fibula, and again, raised the fibula to achieve the optimal restorative space rather than mirroring the inferior border of the mandible. And then we also designed an immediate prosthesis, which you see here on the right. We place it in slight hypoocclusion, so slightly below the occlusal surface, so that she is not chewing on her fibula immediately after surgery. And then here, intraoperatively, you can see that we create cutting guides that's sort of where we design our cuts on the mandible, and then we have a separate guide on the fibula side, and we also plan where we're going to put the implants, so that it's all very accurate. And then here's an intraop photo where you can see this is her right leg. We've already raised the fibula, we've made the bone cuts, and we've secured it to the plate, and we're testing out the prosthesis to make sure that everything aligns like we planned. And again, here's a diagram just showing the fibula is still connected by its blood supply to the leg, but we use this opportunity to make sure all our bone segments fit in our planned defect, and that our prosthesis fits as well. Then we bring everything up to the head and we fixate to the native mandible. So again, this is the fibula. We have our blood supply, because this is a living transplant from your leg to your mouth. We have the abutments that we've placed onto the implants, and then our prosthesis. And again, for this case, we sew the skin of the leg sort of around and under the temporary prosthesis. So this is an image of this patient upon, and again, this is sort of a close-up view of sort of the whole construct. And then on the right, you see this is the patient upon waking up in the operating room post-operatively. You can see that the prosthesis is in place and is slightly below the occlusal line, so on purpose, so that they're not chewing on that while everything's healing. And then this is her latest try on. You can see, now with the final prosthesis, we make it so that it goes up to her occlusal surface. Lastly, I just wanted to briefly show a maxillary reconstruction case and sort of talk about some of the shared decision making that goes on. This is a 70-year-old male with a right maxillary alveolar ridge squamous cell carcinoma. He is a guitar player and a singer in a band. And so given the size and imaging curves of his tumor, it was T1 disease and there was no bone erosion noted on imaging. And so we thought it was unlikely that he'd be getting adjuvant radiation unless there was some new information in surgical pathology. He felt very strongly about not getting a fibula or a scapular free flap, and he also wanted to tour with his band within 30 days of surgery. And so we tried to, after extensive discussion, agreed on using a zygomatic implant perforated radial forearm free flap with media prosthesis. So here you can see we worked with our oral surgeon to design these zygomatic implants as well as sort of a traditional dental implant to fit the defect. And then intraoperatively, the picture on the left shows we took the radial forearm free flap, which is a very thin, pliable, fasciocutaneous free flap, and we used that to sort of realign the defect that was created after the cancer was removed. And then once our oral surgeon placed the zygomatic implants, we perforated the implants through the flap, as you can see here. And then the center picture shows we were able to place the temporary prosthesis on these implants. And again, it's slightly higher than the occlusal line so that there's not undue pressure on the implants while it's healing. Got a post-operative CT scan that showed all the implants were in good position. So, and then the patient, was able to make his concert. In summary, I think dental rehabilitation is very important in terms of quality of life for these patients. And without truly doing the full range of dental rehabilitation, we're not fully reconstructing our patients. This can be done in an immediate or delayed fashion for both the mandible and the maxilla. However, it's a very long process and requires shared decision making. And we do know that the earlier you can implant patients, the earlier you can get them teeth, the more likely they are to have a final, implant-borne fixed prosthesis in the end. And it really takes a team to get the patient to their final prosthesis. And we're lucky to have a big team here at Stanford. So I just want to shout out, we have a great head and neck surgical oncology team. And then personally, sort of my nurse coordinator and my PA have been really helpful in sort of shepherding these patients along the process. And then we wouldn't be able to do this without our excellent dental rehabilitation team, who've really I've worked with very closely to get this done. Thank you.
Thank you, Dr. Chen. So if you would like to look at the questions in the Q&A and address those, Dr. Hohenberger and Dr. Chen.
Sure. It looks like there were a couple questions from my portion of the talk. So for differentiated thyroid cancers with metastatic neck lymph nodes, is a block neck dissection required after thyroid radiofrequency ablation? So this is a little bit of a tricky question to answer because if we're going by those 2025 ATA guidelines, radiofrequency ablation of metastatic lymph nodes, we didn't cover that so much today, but it certainly is an option for patients, but it isn't standard of care. So typically radiofrequency ablation for the metastatic lymph nodes is being recommended for patients who have refused surgery or are not a candidate for surgery. So I would say it's not recommended for upfront treatment of the lateral neck. Typically it's really hard to do a radiofrequency ablation of the central neck if the nerve is still intact because they tend to cluster right along the recurrent laryngeal nerve. But for patients who do have metastatic disease to the lateral neck, a block surgical neck dissection would still be standard of care, right? And it is a level 2 through a 5B. You should always be performing a thorough compartment level dissection up front for patients to give them the best outcomes. And then there is a second question. Is radiofrequency ablation for nodules mostly done in a medical center, or is it done in the private practice setting? There certainly are private practice groups, right? We see, the Russell Center at Johns Hopkins and these centers that are popping up as a private practice center that are performing high volume, high quality radiofrequency ablations. I will also say that with the way that the RVUs have been distributed for radiofrequency ablation, I will say a lot of the costs that you can recover from the insurance companies is coming from the facility costs. And so it is more often being done in large medical centers, right here, like here at Stanford, or and rather than in private practice settings.
Chen, I think there's one from Dr. Jane for you in the Q&A.
Oh, yes. So the question is, to clarify, is that first prosthesis temporary and then they need a more final one made? And that's correct, because we're doing the first prosthesis at the same time as when the bone is being placed. And so we're waiting for the bone to fuse, the implants to osseointegrate. And so we don't want to load anything until we usually wait about 6 months. And so they have a temporary prosthesis that puts them in a little hypoocclusion, and then we'll need a final one made.
I have a question regarding access. How long does it take if a provider would like to refer a patient to you? How long until referral, until scheduled?
I guess I can answer for me. I think we try to get in patients very quickly, especially if they're cancer patients. So within, a week or two. So we try to be pretty quick about that.
And I will say similarly for cancer patients, we can get people in fairly quickly. It's not as quickly as for squamous cell carcinoma. We are, with thyroid cancer, we do tend to have a little bit more time. With benign disease, our referral for RFA is very, very high volume. So it can take months to get in. So we do recommend kind of placing those referrals early and counseling patients that it may be a while to get in, but that it is typically not going to change their outcome, but by waiting. So we do have a backlog of radiofrequency ablations.
And then there's a question, is there more risk of the immediate prosthesis on the free flap? So we've shown that there's no increased risk of like flap failure or flap death after putting sort of implants in a temporary prosthesis. There is some increased risk of infection. And so, as you can imagine, compared to when we sort of seal them off, when we have the temporary prosthesis, we are sort of sewing the skin around these implants. So it's not a complete seal and so we usually put these patients on antibiotics for a couple weeks while they heal, which we don't typically do when we're not doing an immediate prosthesis. But overall, we haven't seen an increased risk of flap death or readmissions or reoperations.
And we're right at the top of the hour. So if you have additional questions, please email me and I will get those answered for you by our faculty. And we will send out this recording to all of you who have signed up for the activity, as well as information on how to claim your CME program. We hope to see you at our next ENT Experts Update program, which will be January the 15th, 2026. It'll feature topic on closing the hearing gaps, amplifications, and implantable solutions for hearing loss. So thank you for joining us and have a wonderful rest of the day.